Thank you for joining me. I want to talk about setting up a successful Foregut Center in a community practice setting. So my experience is in an academic surgery center, but my partners who help me do this thing is throughout the city, and they run their own practices and they will refer patients to me. I have nothing to disclose. My intended audience is for new surgeons entering a community. If you've been doing practice for 25 years and you want to enter this arena without any prior experience, it may be a lot harder. But for the new surgeons who are entering the community, these are the things that I will tell them. And the soft areas will go something like this. Your goal in the community is to be loved by your people there, socially or in the work space. Socially, people want to know if they can connect with you, if you belong to them, if you can sit in the cafeteria and have a conversation with them, or do the things they do, send the kids to the same schools. They want to have that connection. You always have to be available. And I have this one phone call rule. Your referring doctors only want to pick up the phone and make one phone call to you. And I still do that to this very day. When they call me about a patient they want to send, I take the information. I don't say call my assistant at this number. I don't do that. I don't even know the number to call my assistant. I just take the information, and from my end, I send out the appointments and all the things that need, the studies that they need to get done before seeing me. And the last thing is, what do staff say about you when you're not there? They are probably one of your biggest referral sources because they're going to go around town and around the supermarkets and talk about this doctor who fixed my hiatal hernia. These are the nuts and bolts of a community-based Foregut Center. You have to know what your service area size is. Are you in a 5,000 uh, uh, family community? Are you in a 50,000 family community? And if you believe, do the math. If you believe 25% of people suffer from GERD, and only at most 10% of all GERD patients receive surgery, as a surgeon, are you going to have enough to sustain a meaningful practice just in Foregut? I think I've been around a while now, and I think if there's a new gastroenterologist you can partner with, that's the ideal thing. And this is something that someone who can help you co-manage patients, you can bounce ideas off. Somebody who has GI motility expertise is a huge plus. Uh, and I say new gastroenterologist because you're new, they're new, and you have no connections with anybody in the community. And this is a new opportunity for you to build something. The people who are already there already have their referral patterns, and unless you have something new and then you fill a void that they don't have, it's very hard to break into that referral pattern. Um, you need esophageal motility expertise, and that comes with a tech or a nurse who actually does the day-to-day execution of these tests. You need to have the capacity to do a pH study, either the wireless based or the catheter based. You need endoscopy capabilities where you are, and you need radiology to be able to do esophagograms, upper GI studies, and nuclear medicine studies for gastric emptying. And I call this the Foregut 5. You go around in my practice area, even my community referral base know to get the Foregut 5. And with that, you can make most of your decisions. And I'll encourage you to keep that in mind, these 5 things. Very important, and I put this in red, is for you to have an opportunity to steer a multidisciplinary conference. You don't have to run it, you don't have to be the director, but you have to be there and to have a voice and you have to contribute. And in that sense, you steer. My personal vignette is that I didn't want to talk to another GI doctor because I was very self-sufficient. I ran my own esophageal motility lab. But one of my partners, and you guys know Scott Davis, says, you should show up and contribute. And I did. And I think I have locked in the primary, the biggest referral source that I have come to find in the last 2 years. So being able to contribute to a multidisciplinary conference steered is important. A little bit more about that later. So why multidisciplinary uh, team? Well, I'm going to tell you that failure to respond to PPI is no longer the leading indication. When we were growing up, we were taught that people who had bad reflux, they fail to respond to PPI, so they can't take PPIs, they should have surgery. That's really no longer the case. In fact, the GI community, if you read the consensus and guideline statements for the American College of Gastroenterology, there is always a hint that they're steering people away from it. They'll tell you things like, they'll tell patients that 80% of those patients after a Nissen fundoplication are still on PPIs. They'll tell you that the trend for Nissen fundoplications are actually going down in the last 10 years. Um, so they will control patients and hold on to the patients, and they will send you the absolute sickest, the strictures. And that makes it very difficult for you to intervene early on if you're not part of a multidisciplinary team. Um, Complex disease presentations. And some of these patients need a lot of emotional support. If you have a psychologist, which it doesn't come free and it's not cheap, it's always a plus. People in family medicine who have an interest in this, a lot of them uh, enter the area of emotional support work, either by prescriptive means or counseling means. Here's a real case scenario: somebody with dysphagia and hiatal hernia. So which is it, right? What's the primary problem? Manometry suggests spasm, but the flip calls it a esophageal gastric junction outlet obstruction. This is complex. It's no longer somebody who didn't respond to PPIs, and this is another reason why a multidisciplinary team is important. It also distributes the burden of care. You can have patients go back and forth, and you can have if it ever comes to a medical legal thing, you can say that the team approached this patient this way. And the other thing is you learn each other's language. I'll give you an example. What's AChR A3? And it's acetylcholinesterase receptor A3. And this is for patients who have paraneoplastic pseudoachalasia. This is something I had to learn using the language that they do. And there's a panel of antibodies that you can draw for these things. So it's important to learn each other's language. Um, don't assume that everybody knows what you're going to do. One of my biggest GI referral doctors will say things to me like, after you do a helimyotomy, do you do a toupee fundoplication? For me, that goes without saying, but they ask me these things because they need to know that this is how I am doing it. So don't make any assumptions. Be at the table and everybody have discussions as peers. You have to decide what the scope of your foregut practice will be. What can you do? What will you not do? And who will do what, right? And here's a menu of the typical things that people in major foregut practices might do. And this includes redo operations, giant parasopteral hernias, endoluminal therapy, new technology links, uh, robots, achalasia or diverticulum esophagectomies, gastroparesis, bariatrics, non-reflux, non-surgical reflux management. Who will be reading the tests? Do you do these studies all yourself? Do you have the capacity to upkeep this? Do you hire the techs and nurses to do this? Do you have capacity to do intraoperative endoscopy? I know very famous foregut surgeons or surgeons who have to call the GI doctors to come into the operating room to do endoscopies for them. So you have to know what are your offerings. Do you offer Barrett surveillance and treatment? Do you have that kind of time to do something like that? Do you do complex interventions for lesions in the esophagus and the stomach, EMRs, POEMs, G-POEMs, and endoscopic ultrasound? I will say that you don't have to do all these things, but these are the things that make a credible center. Probably I'm going to call it permission to play. You want permission to play, and in this sphere, you have to at least offer these things. Reflux surgery. So you know the difference between anterior to be able to do an anterior, posterior, partial fundoplication, fix the hiatal hernia, and with good outcomes. Can you manage a parasoptic hernia? Intraoperative endoscopy, that is a huge part of what you should be able to do. And in your practice, do you have the Foregut 5 capabilities, either virtually or in your own center? And can you do achalasia? Achalasia is rare, but you have to be able to do that. And if you only do one or two a year, if you have to send it out, go right ahead. Um, And the last thing is, do you use protocols and pathways for these things? If your group can build a protocol and pathway with from the radiologist all the way to the family doctor to the GI doctor, um, that actually creates a center. So it's not a willy-nilly thing. It's not a, oh, this is my experience, and you just keep everything in your head. You really have to be able to have these components to really call yourself a center. The big picture is this: the broader your scope of offerings, including non-surgical approaches, the better you can manage the entirety of this organ system. And I do believe you should have you should gain expertise in this organ system and then find different technologies to fill it. Actually, I didn't come up with this. Stan Smith said these things when I was in training, and I still remember that. A multidisciplinary team, even virtually, can fill any gaps in your offerings. My multidisciplinary team is within my site, but actually throughout the city, I have 3 or 4 motility experts I work with throughout the city that we bounce the ideas off. We send pictures, we send studies to each other, and we talk about it. And my phone's always available to them. Here's an example of a no limits practice. You can do bariatrics and foregut. And this in your practice, they go hand in hand. So you can actually do complex reconstruction as well as fix foregut issues. And this is an example of having some limits. You were looking for a new service line, you got Link certified, and now you want to treat reflux. That's really the other way around, and it's more like I've got this technology, let me try to find a disease for it. Uh, so how do you name yourself, right? What's in the name? You call a heartburn reflux center. I just want you to remember that the number of anti-reflux procedures have gone down over the last 10 years. So if you call yourself a heartburn and reflux center, are you willing to do the medical management, or is your team able to do that? You want to call it achalasia clinic, that's fine, but it's too rare of a disease to build a practice. You'll end up being a one-person island. Swallowing center, this was a name that we had 25 years ago, and you have to say, do you treat anchors? Do you do the upper esophagus? And the options for upper esophageal work is very limited, right? You can do Botox, you can do Zankers, diverticulectomies. Esophageal center, are you an esophageal center? Will you treat gastric cancers with it? Gastroesophageal treatment center is a possibility. I think very few people will call themselves a redo surgery center. They will come if you are busy enough. And dysphagia clinic, that is a very disease specific area that actually surprisingly allows you to see a broad bunch of patients, because patients who have bad reflux sometimes, or even eosinophilic esophagitis, can present with dysphagia. So you will be able to catch a lot of people. So what should we call the center? Well, it should encompass the system or disease you manage best. And I suggest that you do go from the biggest area on down. Now, I like esophagectomies and total gastrectomies, but combined, I probably do a dozen a year, okay? And for me to call that as a center, it's risky. So start from the biggest thing that you do down, and that will be more encompassing for the disease that you manage. You have to say, is this name procedural or diagnostic? Does it give the hint that we're more like surgeons, or does this give you this thing? Uh, the hint that we do a lot of evaluations and diagnosis for this, and they are both very important. They both bring business into the hospital, into the system, so you have to make that decision. Um, what does your practice community want to call it? All right, that's very important. At the end, uh, what do your stakeholders call it? Your stakeholders include the referring doctors, and they have to understand it. And patience. My biggest problem is when you call it foregut, it takes a little bit a re-education. You really have to um, a lot of it's embryology, right? The patients will say, "What's a foregut? I don't understand that." What, and that takes some education. So it may be good for the people who are in societies or who are in the know, and people like us who are listening in right now. And this name has to meet the community's perceived need. For me, you can call it anything you want as long as you're going to refer the patients to me and to us, right? Call me, the call me a band's name if you want to, as long as the patients keep coming. So the community has to understand what they want, what their perceived needs and gaps are, and they call it that. And you work along with that. I think that's probably the most important thing. For me as a surgeon, I am going to call it the Hiatal Hernia Surgery Center, and it's and this is very limited, but I don't have to worry about the reflux business. I don't have to debate with anybody whether they need a Nissen fundoplication or not. When you have a hiatal hernia, it's a very mechanical thing. Very few people argue that you don't need surgery for a 5 to 6 centimeter hiatal hernia. And that is the biggest thing I do. And the Nissens will come along with that. And once in a while, the achalacias, the epiphrenic diverticulum, do come. And but nobody argues with me that this is a surgical problem. But that's me as a surgeon. I But if you're a multidisciplinary center, you probably will want to call it a Foregut Center. And I did a very informal, quick poll, and the initial results for um, what name best embodies what you do. So I sent this a lot of this surgical societies and the GI societies. and Foregut Center still is coming up number one. Reflux and Heartburn Center is still is number two. And finally, I'm going to tell everybody that you are your best marketer. You have to manage your reputation in the OR. I remember this very early on when I was doing a big parasopter hernia, and you have to treat people right. And one day I get a call this is about 2 years later, um, from a GI doctor. And he says, from a GI doctor, I don't know. And he says, I was doing my endoscopy and I said, oh, snap. Um, this this is a huge parasopter hernia, and the nurse in the labs in the GI lab says, there's a guy I know down in Atlanta who actually, you know, um, can fix this for you very fast. And I used to work in the OR with him, and this is somebody I didn't even remember her name. Okay, it was her. Eventually, I did, and I remembered that story. So manage your reputation in the OR. Send pictures, send notes to people. I think handwritten notes and pictures and videos are very important. You want to send them a video clip, they will love it. Remember, if they are virtual, if they don't come to the same conference as you you do, this video is actually your virtual multidisciplinary uh, uh, team. Put them as co-authors. There's an interesting case. Feel free to add their name to the video. If I were presenting a video today, the referring doctor, his or her name will be on this. Send the patient back to the referring GI doctor all the time. If you have issues, let them manage so they will keep the patient flow. Um, the worst thing you can do is actually operate on them and then start scoping, or actually things didn't go right and you're afraid to send the patient back to that GI doctor. You send it to another GI doctor. That's like political and professional suicide for yourself. Um, and here's an example. This is a patient with a huge epiphrenic diverticulum, tight lower esophageal sphincter. I put arrows here to explain to everyone what this should look like, and I sent them a quick follow-up picture after the case was done. Here's a clip that I have there to show what this thing looks like. There's no leak, and it's very telling. You don't have to be a foregut expert to see a difference here. And one of my referring doctors says, "Are you going to do a 7 millimeter uh, um, um, myotomy above the Z line?" And I said, or a 6 millimeter, and I said, no problem, I'm going to do a 7 millimeter. And I typically don't do this, but I cut up a ruler and I stuck it in to show him that this is how I do it as well. Very convincing. You take the time to do these things, educate your peers, speak to your peers as at the level that they're comfortable with, and that's just how you're gonna get this repeat referrals coming to you. And this has worked for me over and over again. And finally, I just want to thank Sages for letting me do this talk. Anna Jane, who runs the Emory Dysphagia Clinic, who has become a great partner and collaborator. The nurses in the esophageal physiology lab, um, and I want to thank John, my partners, John, who actually are who do this. I have many partners, but they are also in this business. John Sweeney, Anka Patel, Scott Davis, Jamil Stetler, Fede Surratt, Lizzie Heckenbleichner, Scott Steinberg, who joined us recently, and Dan Smith and Lena Kitan, who actually built the center that I actually inherited. Lena Kitan and I got into a lot of mischief together, and but we learned a lot from each other as well. We had cross coverage for each other, and we took care of each other's patients. And feel free to email me if you have any questions. Thank you very much.